Hello, everyone. I'm Barbara Ham-Lee. On today's Another View on Health, we examine the roles social determinants play in our healthcare. Does implicit bias matter when it comes to our electronic health records? What about your relationship with your healthcare provider? How important is cultural competence? We'll examine healthcare from a sociological perspective with Dr. Gary David of Bentley University. But first, today is the last day of our fall membership drive, the chance for Another View listeners to support what you love. Let's go to Pledge Central with Sandra Woodward and Kathy Martin. Hey, ladies, how are you?
Good afternoon, Barbara. How are you?
I'm doing great. It's good to talk to you guys. And guess what? We have a $2,000 challenge for the hour.
Yay.
And there's an and. I just renewed my membership. I told them not to input it until right now, so it'll count against our $2,000.
Perfect.
And so I cannot ask the audience to give if I am not a member. So I am a member. I am asking the Another View listeners, now is your time to support Another View. If you like what you hear every Friday, now is the time to show what you love. How about that?
That's leadership right there, isn't it?
It absolutely is.
That is leadership. 1-800-940-7170 is the number to make your pledge of support for what I like to call appointment listening every Friday right here at noon. It's Another View. We've got a dollar for dollar match right happening, and you heard it right from the host. She's already made her pledge, so what's stopping you from making a pledge?
Absolutely. 1-800-940-7170. It's an easy call. Our volunteers are standing by. They're wonderful folks. And just tell them when you make your pledge of support why you like Another View. I'd like to hear some of those reasons so that we can continue to bring you the kind of programming that is impactful for you and that makes a difference for you.
Right, and we'll be sure to read your comments on the air here, so Barbara knows that you love her and you love the program and you love everything that you can count on here every Friday at noon. Another View. This kind of programming, this local programming, is made possible by members of WHRV. You hear us talk about membership drives all the time. This is what they're all about.
Absolutely, and this is the best time to listen. It's the noon hour on Friday. It's take your lunch, listen to Barbara. It's always informative. As Sandra said, always local. It's an amazing, amazing program. So call in, support what you love, 1-800-940-7170, or go online to WHRV.org.
And of course, Barbara, it's Pet Pledge Friday. Did you hear that?
Course.
Did you know? I don't know if that was out there. A little unknown fact here. It is Pet Pledge Friday. So we have been getting all the pledges and calls in for everyone's pets. 1-800-940-7170. It's been a great morning so far. We've heard from everything from horses and cats and dogs and rabbits. We even had squirrels. Wow. But I understand it. Apparently, earlier this morning there were crabs in the mix too.
Crabs?
Yeah, I heard ducks and chickens. There's been a lot. It's been a big morning
and
here.
somebody just called in with swans just before the show started. So
yes.
There you go.
It all counts. And as I keep waiting for somebody to call in with their favorite pet peeve, but that doesn't seem to be happening.
Right.
At least not so far. 1-800-940-7170. WHRV.org. If you're listening right now from your computer, there's a tiny little button up in the top right-hand corner that says Support Now. You click on that, and you're on your way to supporting Another View.
And you do have that $2,000 match for 1 hour. So we only have from now until 1 o'clock where your dollar will be matched dollar for dollar up to $2,000. So if you want to increase your contribution, now is the time to make that call. You're not going to miss the show. Call now. It'll be fine.
Call while we're yakking.
Right. Yes,
exactly.
Exactly. Double your money. 1-800-940-7170 or go online, WHRV.org. Now is the time to donate, and now is the time. Don't wait. Think I'll do it later. Call now. Tell Barbara how much you love her. Donate for your cat or for your dog and support what you love.
Your swan. Your
squirrel.
Your crab or crabs or
whatever.
Right. 1-800-940-7170. And what do you, Barbara, we're talking health today, right? This is your health show.
Yes. This is Another View on Health, and we'll have cardiologist Dr. Keith Newby, who co-hosts that with me every fourth Friday of the month. And we're going to be talking about social determinants and how they impact your health care. Everything from implicit bias in electronic medical records. Can you believe that?
No.
I mean, things of that sort. So there's so much more to just, I don't feel good, doctor, that happens when you go to get health care today. And so we want to make sure that people are aware of what's going on. So that's what we're going to talk about.
You're hearing those phones ring, aren't you?
Absolutely. I'm loving it. I am loving it. And I am so grateful. Thank you all very, very much. You still have time. 1-800-940-7170. That's the number to call and make your pledge of support.
We've got 30 seconds here, Barbara. We're going to toss it back to you. Give people what they're paying for here. 1-800-940-7170. We've got Pet Pledge Friday. It's the last day of our fall membership drive. We've got a dollar for dollar match happening right now only during Another View. So this is the time to make the call. 1-800-940-7170. WHRV.org. As always, thank you for your support. And now it's time for Another View.
Discussing today's topics from an African American perspective, this is Another View.
And good afternoon, everyone, and welcome to Another View. I'm Barbara Ham-Lee. Thank you to all of you who have already made your pledge of support for Another View and all of the programming that you hear on WHRV-FM. We are so very, very grateful. Volunteers are standing by right now. This is the final day of our fall membership drive. Call 1-800-940-7170 and tell them why you love Another View. And remember, if you call during the show, your support will be matched dollar for dollar up to $2,000. So a anonymous donor gave us $2,000, said, if you raise $2, I'll give you $2. So let's show our love for Another View. We really appreciate it. So it is the fourth Friday of the month, which means it is time we talk about health and healthcare issues with my co-host, Dr. Keith Newby, cardiologist. Dr. Keith Newby, how are you?
I'm doing well, and you?
Good, I'm doing great.
Always wonderful to see you.
And always wonderful to have you on.
Well,
absolutely.
I appreciate that.
And joining us by phone is Dr. Gary David. He's an associate professor of sociology and department chair with Bentley College. He's a certified clinical sociologist, and he's also president of the Association for Applied and Clinical Sociology. Gary, how are you?
I'm doing okay, I guess. I thought about that question for a while today, of all days, of how I was going to respond to how are you doing, and I'm fine, but there's so much going on in the world right now. It feels like it's more complicated than that.
You know,
and I guess we can get into that.
Absolutely. And I know that we're going to focus today's show on healthcare and so forth, but I got to ask you, as a sociologist, your take on what you saw yesterday on the air with the Kavanaugh hearings. I mean, what do you think from a sociological perspective is happening to our country right now?
You know, on the one hand, predictable would be my first response. I'm surprised that people are continuously surprised. I mean, I think, as Maya Angelou said, when people show you who they are,
believe them.
Believe them. Yeah, right. I mean, so I tweeted earlier today that, thinking about whether or not Senator Flake and Collins and Murkowski were going to vote against the GOP is kind of like betting on the Washington Generals to win. Once in a while, they will pull it out and beat the Harlem Globetrotters, but typically, if you're going to bet on the Generals, you're going to lose.
Yeah.
And so you see, one of the things we do in sociology is we like to look at systems. We like to look at the big picture, and we like to look at patterns that emerge, and also how sometimes the ways in which we're raised, taught, the experiences we have, blind us to certain patterns. I mean, there's a thing that's called normalcy bias, right? And we like to assume things are normal, and we like to assume that things are the way we were taught they are, and that often can obscure the way things really are. And so watching yesterday, I don't know why anybody would be surprised how it played out in terms of how things were breaking down on different sides of the aisle and approaches taken. So predictable, unfortunate would be obviously another word. And one of the things I just got done talking about in my sociology class was the difference between norms and laws. And one of the nice things about teaching sociology is you can just open up a newspaper any day and point things out. And so, norms are those things that we rely on for people to observe. And when they stop observing them, they lose their power. And institutions are made up of people, and they're only as strong as the people who are in them. And we're in the sociological moment, right, where norms are breaking down, where institutions are faltering, where new orders are emerging. And so as a sociologist, unfortunately, it's a really good time to be in business. I always tell people that if you see a sociologist hanging out in your neighborhood with a notebook, it might be a good time to move.
Because you know that things are about to change. Well,
something's going on.
Something is happening. Are we in a cycle? I mean, is this cyclical in terms of how society rights itself or corrects itself or changes itself?
Yeah, well, on the one hand, yes, it is, right? And so, I'm not a historian, but a sociologist is kind of a jack of all trades and master of none. We got to know a little bit about a lot of things in order to do what we do, to piece things together.
Right.
Not a historian, but I know enough about history to know that there have been other points in our history that you can point to and say, well, it's not as bad as it was then, or at this point it was really bad. I mean, the Civil War was really bad, true.
Yeah.
And 1960s, Watergate was really bad, true. But I think that there's some unique features of today that are beyond just the politics. I think it goes into, as we can talk about with, social determinants of health, it goes into economic changes. It goes into demographic changes. It goes into power changes, right? And one of the things I talk about in my classes is that, when you have these transformative, qualitatively different moments in history where everything's changing, those are ripe times for massive social upheaval because things don't happen quietly. Those who have don't want to give up what they have under these new kinds of orders. So I think on the one hand, it is cyclical. It is a social pattern that happens in terms of intergroup relationships. On the other hand, there are some larger changes afoot that make it, I think, importantly different, such as the massive decline in manufacturing, right? The massive demographic shifts that are happening in the country in terms of its color and composition that are, quite frankly, freaking a lot of people out, right? And so it starts to become intensely tribal really quick. Not that we've never been tribal, obviously we have, but this moment, especially the global tribalism that we're seeing with links across other countries and these kind of, neo-fascist movements that you see rising up, make it different.
Yeah. I tell you, we could unpack a whole lot of things, but let's move to the topic at hand today. Since we did say we wanted to talk about social determinants and health. So how long has the healthcare industry and the sociology industry, if you will, been merging in terms of looking at how our societal ways affect our health? Has that always been a part of the consideration, or did we start out with, okay, we have this disease and this is why we have this disease and it's more physiological and has nothing to do with what else happens in our lives?
Well, you mentioned when you introduced me the Association for Applied and Clinical Sociology. I should mention we're going to have our conference, our annual international conference in Norfolk. Am I saying that right, by the way? How do I say this?
It's Norfolk.
Norfolk. Okay, I want to make sure I got it right. It's coming up in October 11th through the 13th.
Absolutely, and I actually have the pleasure of serving as a keynote speaker at that event, so thank you very much for the invitation.
I want to talk a little about that if I get the chance. We're excited to have you, but get to your question. In the 1930s, a person who was at Yale wrote a paper on the need for clinical sociology. Okay. And the idea behind clinical sociology in the paper that was written way back then was really centered around you can't understand the treatment of an individual apart from the context in which he or she lives. Okay. And so this is not a new concept of, the intersection of health and society, especially, medical sociology or sociology of medicine. It's one of the largest disciplines within sociology is medical sociology. Understandably so, because it takes up so much of, space in our society. And when I say by space, I mean what we think about, how we navigate the world, how much it costs our society, how much it costs us personally. It's a big, obviously, for a lot of important reasons, a big deal. So not a new thing. In terms of what level of prominence it's given, how much attention it's given, what role it plays in shaping how medicine is practiced, the impact and influence of it is increasing, but it doesn't mean it's dominant, right? And so, for instance, I know people who are sociologists who teach in medical schools on doctor-patient interaction, teaching doctors how to communicate better with patients. I was recently at the Mayo Clinic in Rochester, Minnesota, taking a workshop on a technique used to help physicians, clinicians, care workers become more aware of how they act and how they coordinate their care in the medical setting. And so you see the influence increasing both in terms of the practice of it, the understanding of it, and the policy of it.
Let me ask our doctor who's sitting here, Dr. Newby, when you were in medical school, is that a kind of a course that you would have taken? Did they talk about? I know it was back in the dark ages. I get it. No, I'm teasing.
Thank you a lot.
But I'm curious as to whether they taught you about the patient-doctor relationship and how you should treat patients.
Well, I went to EVMS, so they were relatively big on that, and we did take some classes on doctor-patient relationships. It was emphasized, but it wasn't like a separate course per se. But I tell you what you find over time is your ability to communicate. Some of it's going to be your own individual backgrounds. I found some people, doctors, are poor communicators only because of their own life experiences have not afforded them the ability to see other cultures, other backgrounds, to be able to relate. And a lot of medicine to me is relationships. You have to build trust. You have to, but you have to understand people where they are. And that's the issue that I found. Some people have a difficult time understanding people where they are. If you can do that, sometimes you can see through some of the challenges and to be able to afford better care and offer better care. But you have to be able to see that piece. And some people, just have had no experience. You think about how some people may grow up. They grew up in certain types of towns where they didn't see anybody other than their own individual culture. So how can you relate to somebody of a different culture when you've had no experience? So you have to realize that and then try to learn from that. So I found they can try to teach you that, but that's difficult. I mean, how to relate to people, I'm finding that's either inherently something you're able to do. I'm not sure I'm convinced it could be taught. You can improve upon it. But I think some people just naturally can do that. I mean, they know how to relate to anybody in these situations. Other people, not so good.
Not so good. So can it be taught, David? Gary, rather. I knew I was going to do that. Your name, because you have two first names.
Well, I tell people, you know what? In fairness to me, two first names would be Billy Joe or Jim Bob. I got one first name. It's just Gary. But, my grandfather got around this issue by having, his name was David.
Oh, no. Are you serious? Really?
I'm dead serious. That's not a lie. And so I think for him, he never knew if they were messing the name up or not. He just kind of went with it. But that's okay. Getting back to your question, the follow-up on what the good doctor said, there's an emerging area of medicine called patient experience, which I think is important to talk about here for a second.
Okay.
Because I do a lot of work in an area called experience design, customer experience, user experience. And the primary thing in customer experience, for instance, is understanding the voice of the customer. It's understanding the world the customer's journey from the customer's perspective. And, very often in business, maybe not surprisingly, the last person or the last people a business talks to or listens to are the customers. Because they think they're the experts. And in education, right, I might think I'm the expert, and so why do I need to listen to the students? Same in medicine, right? So, I'm the doctor. I'm going to tell the patient what to do. You need to eat more vegetables, without understanding from the patient's perspective what that might entail or what that might mean. And so patient experience as a growing area, there's been a lot of advances in places like the Cleveland Clinic, the Mayo Clinic, a place here in Boston, for instance, like Mass General or Beth Israel Deaconess. We've got some good hospitals here, Brigham and Women's, trying to look at the totality of experiences that a patient has across the healthcare system and really trying to educate doctors on this element of empathy and to understand it from the patient's perspective. And I think what the doctor says is a very important point, that to understand where a person is, you got to understand where they come from, where they've been, and where they're trying to go. And it's hard to do that without perspective switching, without getting into that person's shoes as much as possible. And so that's something in patient experience where sociology is contributing, understanding things from their perspective.
So are they creating in other words, is there a new position in medical school then where they bring in sociologists to teach this? Or how are they incorporating it?
I think, both yes and no. Some schools do, some schools don't. It really does depend on where you're talking about. I would say they should do it more. And I was at Mayo over the summer for a few days, and I understand there was just recently a Ken Burns documentary on the Mayo Clinic. You know, they do employ a lot of social scientists and behavioral scientists to work with their medical staff or their clinical staff to facilitate and improve care delivery, both from designing of, you know, environments or processes or technologies or products to designing better interactions. Right, and understanding, you know, there's this term out there now in business called journey mapping. It's understanding the journey, all points along the process that have an impact on the delivery of that product and the patient's experience with care. And so getting that system totality approach is something that hospitals are trying to do more and more in order to try to, you know, number one, deliver better care, but also get more business, right? Get more reimbursements, get better scores so that, you know, they get ranked better in, you know, by the government. You know, so there's a lot of complex factors going on that are driving this. The overall outcome is hopefully better care delivery that's aimed at the patient.
It's aimed at the patient. So I was reading, when I was doing my research for today, I was reading about this study, and I should have had the gentleman's name, and I don't remember it. But he was talking about how he had done two studies, one with Latinos and one with African Americans, looking at them coming into the emergency room with a broken arm or a broken leg. And are you familiar with this study at all, David? Okay. And so what he talked about was the fact that, are you familiar with that, Dr. Newby?
I'll pick what you about. You call him David.
I know, Gary. Gary. What the researcher found was that Latinos and African Americans were less likely to receive pain medication than white patients who were there. And because, I don't know if that's implicit bias that they thought they could just handle it better, or, but as you look at this whole idea of patient caretaker or healthcare worker interaction, that was just very stark to me.
Gary, can I chime in on this one? Listen, I want before you chime in on this one, I want to make a comment. If you look at the media, look at TV shows and movies, who are the drug dealers? Who are the people using drugs? So that's when I went back to that comment about understanding where people come from. If your experience is what you see on TV, think about it. You will be immediately biased thinking down that path. And I have seen that in firsthand, real time, where I see comments made about patients based on their racial makeup.
Oh, so they should be able to handle it?
Well, they're just saying what their hidden motivations are. Now, the unfortunate reality, and there's the one downside is people will get labeled based on other people. So in other words, say like if you have somebody who their motivation is to get drugs to go out and sell it, which there are some people that do that, and then all of a sudden everybody gets profiled the same way. And then the individuality of the patient gets taken away, and all you see is that racial makeup. So when you look at exposure, that's what I emphasize is the exposure of people to make the bias is based on what they see a lot of times on TV and hear on radio. Think about when they do a news clip. True. They always get the most that's the word I want to use.
They get people that don't, right, exactly. They don't necessarily represent the group as a whole.
And they'll get that person to comment. So if you see this, what's your thought process? Or if you see a TV show that talks about people on welfare or something else, and who do they show?
Exactly.
So if that's what you see, that's what you're going to think. So you're immediately biased, and that's what I'm finding comes into play with a lot of emergency room patients. And a lot of people, this is legit. I mean, they have legitimate pain. But you have to, and what we as physicians should be able to do is look at that person as an individual and not as a collective group. And we will encourage them to say, listen, the pain medicine is not the answer to everything. We understand that you're hurting, but at the same time, my back hurts right now. But I don't take any narcotics for it. But there are people with severe, pain, and they have to deal with it. But it's just unfortunate. So I'm finding the bias comes from media a lot of times, and that's what people see.
Okay. Go ahead, Gary.
Oh, there you go. Good. So there's a school here in Boston, a place called Harvard. I've ever heard of it.
I think I heard of it.
I was looking at their website because what you said, there's been a lot of studies done on pain bias, right? And so I was just looking at a blog from Harvard Medical School on women in pain, disparities in experience and treatment. So, racial discrimination in terms of pain management, yes. Gender discrimination in terms of pain management, yes. My wife, she'd be a good one to have on here right now. She is a licensed clinical social worker, and she used to work at a pain care center. And a lot of pain care centers are popping up because they do med management, right? So someone is in a chronic pain condition, they're on heavy opioids, they have other spinal stimulators, other kind of treatment. Someone's got to manage that pain. General practitioners don't want to manage a person's narcotic intake. So they farm this out to these pain care centers. And she was in situations where someone would come in and maybe, the pill count that they had when they were supposed to come in was off because they said, I was in such chronic pain, I had to take an extra pill or extra 2 pills. And they're at risk of getting kicked out of the program. And part of my wife's role was to assess them behaviorally, personally, as an individual. And going back to what Dr. Newby was talking about, her job was to look at the person. The doctors in the practice might be thinking of like, well, that kind of person or those people or, might be looking at that person not as an individual but as an archetype, right, as a stereotype. And so this is a very real thing because how do you know when someone's in pain and being honest? It's not like it's a temperature, Do you have 104-degree fever? It's a very subjective state in many ways, and we have different pain tolerances. So when you have the opportunity for interpretation, bias is more likely to come in because now you're using your judgment on what you think makes sense, like we saw with the Kavanaugh hearing yesterday. You're using your interpretation of what makes sense versus something that we might say or we might think of as being more objective.
So
so we see that situation happening.
So what about the other way around? What about the biases of patients to physicians? Does that also play in this dynamic in terms of trying to create the best atmosphere to get the best health care?
Absolutely. And, without stepping outside of race and gender for a second, I'm getting old enough now where every doctor I see is younger than me. That's disturbing.
I feel you on that one.
Right? I mean, there's that moment in your life when you go in to see the doctor and you're like, wait, what? I mean, they're all younger than me, and I don't like that. And I'm thinking, what could they possibly know? They are,
exactly.
18 years old. And so that's going to impact how, my trust, my willingness to follow advice, my willingness to listen. And, again, the doctor could talk more about this from his own personal experience. I don't need to talk about for him. But, yeah, absolutely. And, bias is one of those things that we all carry with us. Part of what we try to do, or I try to do as an educator, is get people to be aware by critically examining, being reflexive about their own worldview, about those things that impact, shape how they perceive the world. And not that we can get rid of those biases, but at least we can become aware of when they're operating and when they're happening, so that we don't let them interfere with how we conduct ourselves with others, and also don't interfere with the decisions we make that by and large could be beneficial, but we won't look at because we're biased against them. So,
and if someone's bias causes them to really believe one way, I mean, do you tell them that they're wrong?
I do.
Okay.
Well, so one of the guest speakers at our conference coming up is with Wetlands Watch, right? He talks about how do you talk to people about climate change. You can not believe climate change is real. At some point, your basement is going to flood. Gotcha. I mean, you can't sit there and say, my basement's not flooding, and all the boxes are floating. I mean, I guess you could do that, but at some point, reality does have a way of catching up with you. And so, as a teacher, I don't try to impress my own opinion on people about what I think. But if someone said the sun rises in the west, I'm going to say, no, it rises in the east.
Exactly. So
so we can't get caught in this, it's all subjective, it's all relative, it's all a matter of a person's point of view. No, there are some things we know, and we got to establish that which we know as a foundation to build policy and decision making.
Absolutely. If you're just joining us, we're talking about sociology and healthcare with certified clinical sociologist Dr. Gary David and my co-host for Another View on Health, cardiologist Dr. Keith Newby. Today is the last day of our fall membership drive. We have a $2,000 match for Another View. So let's head over to Pledge Central right now and see how we're doing. How are we doing, Sandra and Kathy?
Well, we got some news here. As you said, there is a $2,000 challenge, and we are more than halfway there. That's all I'm going to say. All right? I'm not going to say exactly how far we are because we want people, we want people to call in and take advantage of this dollar for dollar, but we're more than halfway there.
Oh, that's wonderful. That's wonderful. Thank you to all of our listeners. And as you're listening to the show, you can still call in. That number is 1-800-940-7170.
And this is the time to do it now because Kathy and I have been sitting here listening to your conversation as well. And when you were talking about the doctors being younger than you, we're just laughing so hard because it's so true. Last time I was in the hospital, my husband came and he's like, when did Doogie Howser get hired here? And it's just so true.
Yeah.
But this has been a great conversation. And this kind of conversation happens because of listener support, because you listening right now on this Friday afternoon with your lunch, enjoying this conversation, this appointment listening. You don't wait for it to be anywhere else. You listen on Fridays at 12 o'clock because you know it's going to be here, and it is here because of you. That's what these pledge drives are all about. 1-800-940-7170. Dollar for dollar match happening right now. Final hours of our pledge drive, and it's Pet Pledge Friday.
It's an exciting hour. You love Barbara. You're listening to Barbara. She's got a challenge. Call in. Don't think you're going to call later because right now you can double your money. You can double your money. It's so easy to do. 1-800-940-7170. Go online, WHRV.org.
We've got a nice shout out here to Another View. This is a renewing member, Margot Hazard of Newport News.
Oh, thank you, Margot.
She says, Margot says she loves Another View. It's like visiting a beloved friend.
Oh,
nice.
Thank you. That is so nice.
So thank you, Margot. Taking advantage, no doubt, of that dollar for dollar match.
Absolutely. 1-800-940-7170. Or you can go online if you're streaming us right now, because you can stream us on our website, anotherviewradio.org. And there is a button there. You can push that and go ahead and make your pledge of support. It will count towards our $2,000 match. And we only have about 28 minutes left, if my math is correct, in order to make this challenge. So now is the time to either make that call or go online and make your pledge of support. If Another View is important to you, if you like the programming we're bringing you, and if you have suggestions for other programs that you'd like to hear, please give us a call, 1-800-940-7170.
There's so much stuff going on. We have the challenge, dollar for dollar match. You can double your money. It is Pet Pledge Friday. You can call and pledge in honor of your squirrel, iguana, cat, dog, rabbit, whatever. We will read that on the air. And also, if you make a one-time donation of $120, you can get a pair of tickets to the Norfolk Zoo. So you could double your money, go to the zoo, thank your dog, be a better person, tell Barbara how much you love her. It's so exciting. 1-800-940-7170. Go online, WHRV.org.
And Barbara, we have to throw out a little programming note here. The Judiciary Committee is expected to vote at 1:30 this morning about the Kavanaugh hearing. This afternoon, we are going to go to live coverage of that as of 1:20.
Okay.
So that's going to happen at 1:20 this afternoon, and expected to last until about 3 o'clock. So just a little programming note there. But again, all this coverage, what you're listening to right now, this great local programming, great coverage of what's been going on with the Kavanaugh hearings, is made possible by members. That's what this public radio station, this local public radio station, is all about. And when you are a member of it, you are supporting it, you are making it happen. 1-800-940-7170.
Thank you. And you listen to this show differently when you are a member, because you really feel a part of it. And then when you have guests like Dr. Gary David on and Dr. Keith Newby here, you're getting all this information. Our guest, as you can tell from our conversation today, has been kind of free-flowing, but we're getting in a lot of information, a lot of things for you to think about in terms of your health care. You won't find that anywhere else on the dial. 1-800-940-7170. Only takes a couple of minutes to make your pledge of support, and we appreciate it, and we thank you to those of you who have already made your pledge. Help us to reach that $2,000 goal.
We have, want to thank, like I said, Margot Hazard's renewing member. We're also welcoming a lot of brand new members into the family during this drive. Nancy and Richard Guy are brand new members to the family. They pledged in honor of their dogs, Jasmine and Rosie. Thank you for your pledges of support.
Thank you.
1-800-940-7170. As Kathy just said, there's so many reasons to pledge today. You can thank your dog and cat or squirrel or rabbit or whatever, but you can also get advantage of this one-for-one match, dollar-for-dollar match. 1-800-940-7170, WHRV.org. Let us hear from you. Back to you, Barbara.
All right. Thank you very, very much. And if you're coming back with us, we are talking about sociology and healthcare with certified clinical sociologist Dr. Gary David and my co-host for Another View on Health, cardiologist Dr. Keith Newby. So, Gary, I have a question for you about, you did some work on electronic medical records.
I did.
And you talked about some bias there. And I'm just like, okay, that's a computer.
Yeah?
Who programmed it?
Who programmed it? So tell us about your research. What did you find?
Well, it actually started, I was researching a profession called medical transcriptionist.
Okay.
And I'm basically the only person who's ever researched it because no one, I guess, considered that the work that these primarily women do was worth investigating. And so someone, and Dr. Newby can comment on this as well, but, making a medical record is not just a matter of a doctor saying what happened. And I've actually listened to physician dictation, and it's often, what's the best way of putting this, a hot mess. I mean, there's a lot going on. There can be, hitches, restarts, pauses, corrections, background noise, a lot going on. Physicians might be on cell phones and signal might drop out. And so the version of the record that gets into the healthcare system is not what a physician says over the phone. And so the medical transcriptionist job, and this goes way back when stenographers would sit in exam rooms, their job was to make the physician encounter into a usable medical record. All right? And so my research was really trying to understand the skill and competency inherent in doing that work. And also then what would happen when that job, if that job is replaced by electronic health record systems. Okay?
Mm-hmm.
And one of the assumptions that was made was, well, these women, primarily, all they did was type what physicians said. Mm-hmm. And we published some papers on this that showed very clearly, demonstrably, simply, this was not true. There was an important quality control, quality assurance function that was performed by having someone, in essence, proofread what a physician was saying. One of the things I tell my students all the time, have someone else read your work because you won't see the errors you make.
Right, exactly.
The challenge of the EHR, one of the challenges, besides all the technical challenges of things like we call interoperability, systems talking to one another and whatnot, and usability, a physician be able to go onto the machine and use it efficiently, is the reproduction of errors. Because one of the ways in which a system can be used is that a physician will copy a record from one visit and paste it into the next visit. So there's this copy and paste efficiency model that can be built in. And that's fine. It saves time if everything's right. If anything's wrong, then you have a problem because of these errors being duplicated across the system. And most people never read their medical record. And by the way, when I think you read physicians, most physicians don't necessarily want their patients to read all of the medical record in terms of narrative content because it's not for the patient, it's for the physician. So it becomes a rather complicated situation around what impact these new technologies have on physician workflow, patient literacy, healthcare administration, billing and reimbursement, rescission with insurance companies. We could talk about that issue. So it's not just we have a new computer, isn't that great? There's a huge potential impact on how healthcare is delivered as a result of it.
And Dr. Newby is sitting here grinning and shaking his head, so I'm going to let him speak to this.
Well, no, I'm just laughing because you're absolutely right on a lot of it, and there is, unfortunately, so a lot of cut and paste that you do because you have X amount of time to see X amount of people and get this data in there. But I'm laughing to myself about a comment he made about you don't want the patients reading all their medical record because I tell you what, the funniest thing that I've run into all the time. Okay, patient comes in and, they come in with chest pain and I have to do an evaluation so you get the history. And, they'll visibly look short of breath and, sometimes they say they will, sometimes they don't. And a lot of times patients will forget what they said on your visit. So they get the chance to see their record. And they'll come to you like 2 years later. I was looking at this and I'd never been short of breath. And I'm looking at them, and I'm sitting there saying, how do I respond to this without sounding condescending? Mm-hmm. And I've had people who you will ask them, and I'm going to do be a little animated with this, but I'm talking to them and I'm asking them if they short of breath, and they'll sit there and say, no. And I'm listening, and you look at them, and I'm like, are you serious?
Yeah.
You know, there's a reality, there's a reality miss that a lot of people have, and I try to tell people, I said, listen, you're thinking, when you hear the term shortness of breath, you're thinking that you can't barely breathe, but shortness of breath, by definition, is an awareness of your breathing. You know, because most of the time you think about it, you don't think about breathing, you just do,
You just breathe.
and you don't think about it. But when you say, if you're running, you know, and then you're going to be aware that you're breathing harder. Mm-hmm. By definition, that's shortness of breath. And the question becomes, is that a medical issue or that just a physiologic issue? So you have to run into those dynamics with people in medical records and interpretation, because in their minds, I tell you what it boils down to, a lot of them are worried about is the insurance carrier is going to ding them because of whatever their record says.
Well, but I mean, is that a reality?
It definitely is. I mean, the downside is that the insurance companies rule the world. I mean, it's so frustrating for us as physicians that I have to fight. Like if I have a patient that needs an MRI, and I got to fight with them to get it. You know, and it kind of goes back. I forget the name of that movie, but I always reference it, but I never remember the name of it. Matt Damon was in. He was a attorney coming out of law school, and he was involved in a case where they were suing an insurance company. The mother was suing them because they refused a bone marrow transplant for their kid. And I mean, I'm gonna tell you, and I'm convinced that there's a lot of truth. There's a John Grisham movie.
Okay.
And when you look at what they were saying in that, the insurance companies, when he got his hands on their employee manual. The employee manual, they had two copies of it. One that they brought to court, and he got his hands on their real one. But the first thing on their manual was first deny all claims. Because if you really think about it, psychology is this: how many people are going to fight it once the insurance company does not? And it's just like if you hear this thing, the late night shows, they're trying to sell some, totally guaranteed 100% you get your money back. So you call the number and they put you on hold for 2 hours, to try to get your money back. I mean, it's the dynamic that, unfortunately, so they know the psychology that you're going to do, how well you're going to fight, and you're constantly paying money into this plan. But when you look at what you're getting back out, it may not always be what you think. So you got that psychology to deal with too. So yes, to answer the question, a lot of insurance companies will ding you, even though they're not supposed to, based on the Affordable Care Act.
But based on what they see in the medical record.
Yeah, but they will do that because that's why they don't want certain things in there. If they're smoking marijuana, and I mean, you're documenting things based on truth and realities. But if an insurance company sees certain things, then all of a sudden, here come your premium may go up or whatever the case may be. I know by law it's not supposed to, but we know realities, there's ways of getting around things. So you have to deal with that. So a lot of people, or worse yet, not so much the insurance companies, as much as say, like if you want life insurance,
yes,
they will get you for that. If you got in there that you had an abnormal EKG, that EKG may not be abnormal in the sense of there being a medical issue, but you're telling the truth. It is abnormal. But how people interpret that, because you got people who are maybe high school graduates that look at all they got is a checklist. What does this medical record say? And if it says one thing, boom, you're denied, and then you have to deal with that. So that's the kind of dynamic we have to. You talk about sociology. We live sociology every day.
So, Gary, also, when people are inputting like their numbers, I guess, that go along with the diagnosis or whatever, was that also an issue in terms of correctness in terms of these medical records?
By numbers, you mean what do you mean by numbers?
I thought that there were certain diseases that had codes,
so
that
coding,
you could code in,
ICD-10 codes.
Right, right.
So it's kind of interesting. So, and Dr. Newby can talk about this too. Coders can only code conditions or diseases that are present on a record. They can't code symptoms. And often what a physician will do is they'll write down symptoms and treatment, but not diagnosis. And there's a whole profession that's emerged in the United States healthcare system called clinical documentation specialists. I've done some research on them too. And when I've talked to these individuals, primarily women, often former nurses or current nurses or coders, they'll say, my job is to make the patient look as sick on paper as they are in real life.
Oh, wow.
And it's for the purposes primarily of billing and reimbursement and hospital scores and case mix indices and severity of illness indicators and all these other things people don't know about that actually drive what Dr. Newby was describing. And so a coder, a person, and it gets even more complicated. I don't want to bore people because I know you got a fundraising drive going on. But it even gets more complicated because if a condition is present on admission or hospital acquired, it affects how a hospital can or cannot regain reimbursement for that thing that was being treated.
Yeah.
And so if you get someone transporting from a nursing home, they may have had something in the nursing home, but they say they got transferred for pneumonia. But, and then they developed sepsis while in the hospital. Well, the sepsis may have been present on admission, but no one coded it.
But nobody coded that.
No one wrote it down, so now it doesn't exist as reality. And let me just say this point, Dr. Newby. You can go back to Dr. Newby. Doctors don't generate revenue. Documents do. No one gets paid for what a doctor did. People get paid for what the document says the doctor did. And so the medical record becomes the central thing that makes healthcare as a system happen. Now, Dr. Newby can treat people without a medical record, but as a system, it's that document that is what we would call in sociology a boundary object. It goes across locations and is supposed to coordinate activity. So the document is the central thing. So anything that affects the document, like an EHR system, is going to affect how healthcare is administered.
So what as a consumer of healthcare, is there anything I should be doing or could be doing to pay it to make sure that, on a personal basis that your records are correct and that, that you find a culturally competent doctor and you do? I mean, it just sounds like there's so much more than just somebody please help my aching back.
I would first I'll get a copy of your medical record and make sure it's right. There have been cases where people have lost their insurance coverage due to errors that doctors made on records. Okay, and doctors have admitted they made an error on a record. And doctors are human, as you know. Yes. Dr. Newby is probably happy to hear. Doctors are human, and they make mistakes. And so read your record, get a copy of your record, talk to your friends, your relatives, your neighbors about who they use as physicians. Parents do this all the time, right? When you have a new baby,
yes,
new parent,
always get a referral. That's true. We only have about 7 minutes left in the this discussion, and I want to talk about the mental health piece that you're working on. Actually, we have 5 minutes left, according to my producer. But you are working, or you've been doing some studies on apps for mental health. Yeah. Is that right? Can you tell us a little bit about that?
With a physician at Beth Israel Deaconess Medical Center here in Boston. His name's Dr. John Toros. He's one of the leading figures in this area of digital psychiatry. He actually had a phone call with him yesterday, and they just got approved for a digital psychiatry mental health clinic. And what that means is the integration of mobile technologies, like apps on your phone, into clinical care. And one of the challenges of this is that there's so many apps in your Play Store or your iTunes Store that claim to help with mental health status, but they have not been tested adequately to determine what their impact is, either positive or negative. And so there's a big area of business emerging around, especially as we're all stressed out over life right now. We all need it. These apps are supposed to help with your mental health status. So what we're trying to do is, number one, study the impacts of these apps on workflow, on clinician practice, on patient care, but also developing new apps from a patient, not just a patient-centered perspective, but a clinician-centered perspective, because clinicians need to be included in this conversation too. The patients aren't the only one using the information on these apps. Clinicians are going to be held accountable for them as well. And so we have to understand from an ecosystem approach everybody's perspective on the role and impact of these technologies.
And so are you also testing it frightens me a little bit that people just get an app and go on and kind of doing a self-diagnosis as opposed to starting with the medical professional.
Yeah, well, yeah. I mean, I'm sure Dr. Newby could talk about people coming in with self-diagnoses from, WebMD or something, right? And, on the one hand, it's empowering. On the other hand, it's frightening because now everyone's an expert, right? What do you know? You just went to medical school, right? I mean, well, they did go to medical school. It's like it should count for something. So it's on the one hand, patient literacy and empowering patients to take charge of their own mental health, physical health is important, and we should be doing it. And on the other hand, we also have to know what we don't know.
Absolutely.
Right?
Absolutely.
We need to know what we don't know and what other people do know and be willing to listen. And, there's a whole other conversation about vaccinations and other kinds of issues as well. But that's the issue.
Well, I'm going to give you, though, the last 2 minutes to tell us again about the conference. And because anybody can come, or there are certain sessions that are open to everyone. Is that right?
Well, yeah. So on the first day, October 11th, we're having 5 different professional development workshops. And they're on a variety of different topics. And our goal is to bring sociology to the community, okay? Mm-hmm. And the topics that we're covering, I'm doing a workshop on something called experience design, ethnography for experience design. There's a workshop on diversity in the workplace. There's a workshop on qualitative research, qualitative grant writing. So you got a lot of universities around there. Mm-hmm. There's also a workshop that's on applied sociology programs. So we have a lot of different workshops going on. Those workshops are free to conference attendees who are registered, only $25 if you're coming in from the outside. And there's a workshop on social entrepreneurship. So if you're interested in developing a social entrepreneurship, product, that's your workshop. Okay. And we also have a one-day rate if you're really interested in coming listen to Barbara talk on Saturday.
That's Saturday, October the 13th at noon.
At noon. For $50, you can get the day rate. So that includes breakfast, it includes lunch, it includes all the workshops, not the workshops, all the sessions that are going on that day. So all you got to do is come down to the Main in Norfolk and come on in. I should also mention we are doing voter registration there.
Absolutely.
So if you're in the downtown area, we got the League of Women Voters coming down. I believe they're going to be there on, I want to say Friday. I can double check that real quick. And they will be registering people to vote as well as running a workshop on how to run a voter registration drive on your college campus. That
is fantastic. Dr. Gary David with Bentley, is it college or university?
It was college when I first started there 19 years ago, but then we upgraded.
Okay, so now it's university. With Bentley University in Waltham, Massachusetts, and we thank you so much. Also, the 2018 annual conference of Association for Applied and Clinical Sociology, Translating Complexity into Action. It is October the 11th through 13th at the Main in downtown Norfolk. Thanks so much for joining us, and we'll be right back.
I'm with Marcellus, and you all are checking out Another View. Don't go anywhere. Check us out.
And welcome back. A Hampton boxer who has won dozens of bouts on an amateur level is gearing up for his first pro fight. Carl Parker Jr., who goes by the nickname CJ, recently sat down with our Lisa Godley to talk about his life both in and outside the ring.
Carl Parker Jr., known to his friends as CJ, has been lacing up his boxing gloves since he was 15 years old. And with close to 40 amateur bouts under his belt, he's done well. In fact, in 2012, CJ took home the Virginia-North Carolina Golden Gloves title. He says boxing has changed his life.
It's opened up avenues that I didn't know were possible. I've gotten in incredible shape. I've met a lot of people. I have a lot of friends all over the world who all do the same exact thing that I do. So that's always kind of cool.
Now this 25-year-old Golden Gloves champ is making a change, going from amateur boxer to professional fighter. But one thing that hasn't changed during the transformation from amateur to professional is the intensity of CJ's workouts.
We have to train like we're getting in there for Mike Tyson pretty much. And he's not even in the same weight class, but we got to train like it. I do a lot of different training, not necessarily the same kind of training everybody else does, but a lot of cardio. My workout usually consists of jump rope for about a half an hour as like a warm-up. followed by jumping jacks, push-ups, sit-ups, burpees, running drills, push-up drills, sit-up drills, weights, ring tactics, heavy bag work. We do mitt work. We basically try to cover the whole body every time we work out. So every single time I walk out the gym, I feel like I got hit by a car.
Not to mention a diet that the average person probably wouldn't envy.
My breakfast usually consists of a protein shake, followed by eggs, a lot of protein, low carbs, low sugar, low fat. Dinner usually consists of chicken and broccoli, or chicken and green beans, fish and broccoli, fish and green beans. Broccoli is one of my favorites because it's got like nothing in it.
When he's not in the ring, CJ works as a patrol service officer for the Hampton Police Department.
A patrol service officer is like a part-time cadet. We do escorts, we do abandoned vehicles, parking tickets, traffic violations, we do that kind of stuff. It's from 6 a.m. to 11, Monday through Friday, so I'm off every weekend, which is cool because it doesn't mess up my training. I'm off at 11 o'clock, usually I'm in the gym at 12 o'clock, so it's cool.
Being in shape comes in handy for that job as well.
I'll pull up at a disabled vehicle at work in a second and be like, okay, hang on, I'm gonna push the car at the intersection. And they're like, you want some help? I'm like, nah, I'm good. I push cars as training at work. So I'm like, no, just make sure you put the car in neutral and I'll get the car at the intersection. I push plenty of cars by myself, it's no problem. So I'm good for it.
In his spare time, CJ utilizes his associate's degree in photography and takes pictures, or listens to his favorite genre of music, which is country. He says he's a huge Rascal Flatts fan. And his other favorite pastime? Running.
My mile time currently is like 5:25. My 3 mile time, I can get that in under 20 minutes. Easy work. And it just comes from me just running all the time. Training requires running. That's so you really don't get tired in the ring, so I run all the time.
For young athletes interested in pursuing a career in the ring, CJ's advice is to go for it.
Don't necessarily rush into getting your first fight. Get in the ring, get comfortable doing the whole thing, make sure your technique is everything is good, and then, build up at that point. Boxing requires a lot of work. You have to want it, you have to train, you have to eat, sleep, and breathe this game, because there's always somebody out there who's trying to work just as hard as you, if not harder than you. So your goal is to just work. If you have good work ethics, we can make it happen.
For Another View, I'm Lisa Godley.
And CJ's first professional fight, originally scheduled for last weekend, was postponed until December the 8th. But we wish him well, and I'd love to see him out there pushing those cars. So I checked in with Pledge Central, and it turns out, thank you, listeners, so very, very much, we raised over our $2,000 goal. We actually raised $2,835 in the hour, which is now, Lisa, I'm trying to figure out this math because $45.80, maybe more money is coming in. But thank you so very, very much for all of you who made your pledge of support during this hour. It just goes to show the management here at WHRV how much you enjoy Another View. And becoming a member means that this is your radio station, this is your show, and this is your listening opportunity. And so we just want to say a very special thank you for supporting Another View. And you will also listen to the show a little bit differently now that you're a member. So those of you who are brand new, thank you so much for coming in. We appreciate that. So on behalf of Lisa Godley, audio engineer Todd Washburn, and myself, thanks for believing in us and showing it with your financial support. And next week on Another View, the personal story of the reconciliation of a white slave-owning family and the offspring of their slaves. Very, very interesting story next week. Our theme music was composed and performed by Jay Sennett. Lisa Godley is our show producer. Todd Washburn is our audio engineer. And Janae Jackson answered our phones. There's still time to call and make your pledge of support. 1-800-940-7170. We thank you and thank you for listening to Another View.